On Tuesday morning, we had a special session on metabolic interventions for cancer risk reduction, specifically breast cancer risk reduction. And I had the opportunity to speak about the use of Incretin mimetics, the new class of weight loss drugs, which have been incredibly successful at inducing weight loss and controlling diabetes. There have now been observational data sets using national databases indicating that the use of these new weight loss drugs is associated with a reduction in the incidence or risk of multiple obesity-related cancers. Now, postmenopausal breast cancer is not on that list. However, these studies need longer-term follow-up, and I suspect that we will see a protective effect against postmenopausal breast cancer. I reviewed data that our group and others have published showing that obesity and metabolic dysfunction and dysfunction of the adipose tissue can lead to things like inflammation, higher levels of hormones like estrogen, and the production of inflammatory cytokines that also work as growth factors, which can stimulate the production of more estrogen and can also directly stimulate tumor growth. So one intriguing hypothesis is that if we can effectively reduce adipose tissue and reduce weight, we might be able to not only reduce the risk of breast cancer, but also reduce the risk of breast cancer recurrence. Now, it would be ideal to do this through lifestyle interventions like diet and exercise, but those can be difficult to maintain, especially for folks that are starting off with something like class 3 obesity. So perhaps the use of the Incretin mimetics would be a good starting point, and perhaps maintenance of optimal weight or optimal body composition through a lifestyle intervention would be an ideal approach. But we do need randomized control trial data addressing this. We did see observational data, additional observational data presented here at San Antonio. Specifically, we saw Dr. Sukumar and colleagues' study, which reviewed their retrospective experience in a population of over 1,000 patients treated at MD Anderson Cancer Center who were breast cancer survivors and received an Incretin mimetic weight loss drug. What they found was that the amount of weight loss associated with these drugs in the post-diagnosis space was a little lower than what we saw or what was reported in non-oncology populations. There in non-oncology populations, we expect about a 14 to 15% weight loss with the dual receptor agonists. In Dr. Sukumar's study, they reported more of a 3 to 5% weight loss, which is actually consistent with our experience at MSK. Earlier this year at ASCO, we reported in a much smaller study a similar amount of weight loss in breast cancer survivors. So that opens up the question of, should we be dosing the weight loss drugs differently in an individual who is on hormone therapy for breast cancer? And we certainly will need some randomized control trial data to address that question.